forward. All right, so thank you so much, Dr. Kipnis.
All right, thank you everyone for attending and welcome. We're going to be talking about all different types of weight loss strategies. As you said, there are 3 surgeons who are part of our practice. Myself, I've been here for about 15 years and started the weight loss program about 15 years ago. Dr. Arumugam joined us next several years ago, and Dr. Gurley we've also known for several years and recently joined our practice for 3 bariatric weight loss specialists at Jersey Shore Medical Center. Can we go to the next slide? We're going to be talking today about the weight loss program at Jersey Shore Medical Center. Obviously, obesity in the United States is a major issue. There are many different weight loss strategies that have come up and have been changing, especially over the last 2 to 3 years. And I know Dr. Rimon is going to talk about all those different types of strategies that change. There's weight loss medications and weight loss surgery, and we are happy to provide the best options to maintain weight loss in the long term. And we like to see all of our patients really do well for longitudinal care and long-term care with the help of our team, our registered dietitian, our bariatric coordinator, to really have everyone do well over time. Do the next slide. Overall, we've been a bariatric center of excellence since around 2012. We were renewed this past year. That means our data is tracked nationally. We are the only center in New Jersey that has all 3 criteria of a bariatric surgery center of excellence. We handle adolescent weight loss and weight loss surgery, as well as we have certification in obesity medicine. So again, we're the first state, and I think we're still the only program to have all 3 of these qualifications. And our data is better and our outcomes than most national averages. And that's why we were able to obtain and continue to expand these certifications with the American College of Surgeons data that tracks these programs. Next slide. As I mentioned, I'm the director of bariatric and robotic surgery. Dr. Arumugam is the director of our adolescent bariatric program and as well as the director of obesity medicine. Dr. Victoria Grilli joined us this past year after working with us for the last 5 years, as well as completing a bariatric and minimally invasive surgery fellowship. We have PAs who help us make sure that all of our patients are getting exactly what they need in terms of preoperative workup for surgery, as well as assisting with our prescriptions, medications for the newer weight loss medications. We work with a dedicated registered dietitian who helps and intervenes with all of our patients to help make sure that not only are we doing procedures and interventions involving surgery and medication, but people are making lifestyle dietary changes to help them do well over time. We work with the pediatric team here at Jersey Shore Medical Center as part of our adolescent program. And we have a dedicated RN who is Ellen Tizio, who is helping to coordinate your in and outpatient stay, as well as your long-term and short-term follow-up. I'm going to let Dr. Arumugam take over from here, and I'll be available for questions at the end. Next slide, and I'll...
if you want, you could do this slide too about our program.
All right, great. Again, I've been here for about 15 years. We've done over 12,000 operations. The majority of our procedures nationwide, as well as that program, are sleeve gastrectomies. Nationwide, sleeves account for about 60% of weight loss surgery. We do a large amount of revisional operations, including gastric bypass and other changes in operations. We used to do banding many years ago, but stopped that around 2013 because the sleeve really helped to replace that. Leak rates nationwide can be around 1%, and that's 1 in 100. We're running a leak rate about 1 in 200. So we really don't see leaks or complications very frequently. And this is our general statistics for our program. These are far lower than what is considered national average. And that's always been our goal, is to really maintain a safe and effective weight loss. And today we're doing medical treatment, surgical treatments, and sometimes we're doing both together, before surgery, after surgery, or in lieu of surgery. So we really are able to offer all methods that are FDA approved for all management of weight in the long term. Dr. Arumugam, you're up.
Thank you. All right, so I'm going to start our discussion now. Thank you for having me today, and thanks everyone for coming to listen to our talk about weight loss strategies. So we're going to start with the BMI, or the body mass index, and this is our tool that we use to determine a person's health risk, essentially contributing from their weight. We know that the BMI is a calculation that uses the patient's weight in relation to their height. And it gives us a number, and we start talking about weight loss options, medical medications, or surgical, starting at a BMI that's in the overweight category. So that's in the 25 range. A BMI under that, 18 to 25, is considered a normal, healthy weight. Next slide. So as far as obesity trends in the United States, what this diagram is showing us is the prevalence of obesity by state over the past several decades. So we're looking at top left is going to be 1990, and then the bottom one is going to be in 2010. So every 10 years or so, we're seeing this natural trend for the prevalence of obesity to increase by state and really across our country. The prevalence in 1990 was somewhere in the 10 to 15% range or so. And then in 2010, now we're seeing more of the orange shades showing up. And that's a prevalence of about 25%, really across half the country. Next slide. In 2022, we redid this survey, and what we're finding again is that the trend is continuing to increase. Most of the states are now highlighted in the dark orange color, and this is a prevalence of obesity of 35% and even greater in different parts of our country. Next slide. So the obesity prevalence in adults in the United States in 2020 was averaged about 42% across the country. And this is a large increase from 2000, when the number was about 30.5%. We're seeing that same change happen in adolescents. So in 2020, the prevalence was almost 20%. Compared to 2000, it was about 13-14%. So we're seeing this problem occur in both adults and in the adolescent population. We know there are several obesity-related comorbidities, and those include things like heart disease, asthma, sleep apnea, cardiovascular disease, strokes, heart attacks, type 2 diabetes, as well as a number of different cancers. Overall, what this results in is early mortality for those patients that suffer from obesity. The annual medical cost of obesity in the United States was $173 billion several years ago, and this amounts to almost $2,000 increase in cost in patients that are obese compared to those that are not obese. Next slide. So obesity in our country has several different causes. We know it's multifactorial. These are just a few of those things. So social causes, that could mean things like stress, lack of sleep. We also have economic factors, things like the cost of healthy food or going to a gym. Hormonal factors also come to play. We know there are specific hormones that are involved in appetite and hunger, as well as some of the other hormones that relate to fat absorption and fatty distribution in the body. Metabolic effects are there as well. This could be related to side effects from medications, genetic factors. We know that there are at least 15 genes that are responsible for the development of obesity. And we often see that obesity does, run in generational families. Environmental factors come to play as well. This has to do with something as simple as access to parks, safety in parks, the fact that we are all driving to work, we're not walking to work anymore, we sit at a desk all day. So all those kinds of things can contribute to the development of overweight and obesity. Next slide. So as far as weight loss strategies go, this is kind of a very simplified way to think about it, right? The calories that you take in, what you eat, versus the calories that you put out, what you burn. So that's including exercise and physical activity. And we know it's not this simple. I just said that in the last slide, that a lot of things really come to play as far as weight gain and weight loss. But this is kind of a simple way for us to describe it to patients so that they have a sense of how important food is for giving your body nourishment, but also how much it could affect weight, as well as how important physical activity is in helping to be healthy and to lose weight. Next slide. So we're going to start off kind of with the basics as far as options go for weight loss and weight maintenance. And we're going to go into kind of the more complex things or the later on options if it becomes necessary. So first of all, it's going to be healthy eating. So we know that healthy eating, reduction of caloric intake is going to be important for weight loss. So that means we want to increase the things on this list. So things like vegetables, fruits, lean proteins, low fat, forms of dairy foods, whole grains, as well as using certain oils like good fats compared to others. And then we also want to limit the amount of things that have added sugars and saturated fats in them, with the goal of less than 10%, each of those things taking up less than 10% of calories per day. And also limiting things like sodium, which we know can correlate with heart problems and cardiovascular issues as well. Next slide. So physical activity is going to be the next thing we recommend for patients. So what is the goal? What is the physical activity that we should be doing? So what we typically recommend is a moderate intensity aerobic activity. That could be walking, swimming, bike riding, doing yoga. All those things are good options. We want heart rates to rise to some degree during those activities. And then how much do we recommend? So for weight loss purposes, we recommend 150 minutes per week of exercise. For weight maintenance, what we actually need is more in order to maintain weight. That's going to be about 300 minutes per week. In addition to the cardio or aerobic exercise, we also recommend muscle strengthening activity, so weight training, resistance bands, things like that, because the goal is also not just for weight loss, but we want the weight loss to be in the form of fatty tissue that gets lost and in growth of lean muscle. So part of the reason why, it may be counterintuitive to think, why are we actually requiring more exercise for maintenance? It actually makes sense because your metabolism actually slows during the weight loss process. And at a lower weight, your body actually needs fewer calories. So we kind of have to work a little bit harder as we're making progress too. Next slide. So what do results show as far as recommending diet and exercise to patients who are trying to lose weight? A healthy goal for weight loss is going to be somewhere between 5 to 10% weight loss of total body weight over 6 months or so. And what we find is that patients, for the most part, can do this with diet and exercise, but the problem really is long-term. And that's what this graph shows us. Most of those who successfully lose weight will regain the majority of that weight within the following 2 to 5 years. So what we're looking at here is years after weight loss and the percent of weight lost that is then regained. And what we're finding is that at 2 years, most people have now gained back over 50% of the weight that they initially lost. By 5 years, we're seeing that number climb to about 80% of that weight is now regained. More than 2 years after a diet, over 80% of people who've lost the weight have now regained the weight back. And most people, and patients tell us this, have tried to lose weight 2 or more times in their life. This is the yo-yo dieting we see. It works, then they stall and they can't lose any further. And then they kind of lose those habits, which causes the weight gain. So this is really a struggle. We of course promote diet and exercise. It's important for any weight loss plan, but results really show that it's really hard to maintain the weight loss just doing those things. Next slide. So then what can we add to that? We can add weight loss programs to that, which is what we try to offer at our office. We're not just telling patients to start medications or have surgery and eat healthy and do it. We're telling them to do those things, but then follow up with us also. And the goal in this is really for making lifelong changes, behavioral modifications that can really stay with patients forever. This may include weight loss counseling sessions, follow up with nutritionists, dieting plans that are really individualized to different patients. And it also provides regular feedback and support to those patients. Sometimes we use apps or logging of foods or smartphones, things like that to really make it easier for them. So next slide. And what studies show actually is that these weight loss programs improve outcomes. So what we're seeing on this graph is time after the weight loss program is started and the amount of weight loss that we're seeing. And what this shows is that with the maintenance visits, which is the line in red, we're seeing more weight loss maintained over time compared to those that don't have those maintenance visits. So now we're saying diet's important, exercise is important, but long-term follow-up, these kind of long-term programs are really important for maintenance of weight loss. Next slide. So now we're going to talk about medications. This is kind of the hot topic everywhere. And we're going back to the BMI here because the insurance companies, the FDA, approve these medications for certain BMIs, not for everybody. So we're looking at a BMI that's equal to or above 27 with at least one obesity-related comorbidity, and that could be things like type 2 diabetes, high blood pressure, high cholesterol, sleep apnea, PCOS, or a BMI equal to or above 30, even if they're completely healthy. Next slide. So as far as options go for medications, we have several options. We have those that are oral pills. We have those that are injectable. I didn't put all of them on here, but essentially, in general, what the medications do is that they cause appetite suppression. Different neurotransmitters are sent to the brain. They cause less hunger. Sometimes they affect cravings and food choices. Phentermine, Qsymia, which is also a phentermine-containing product, Contrave, metformin, sometimes we use. Orlistat is another medication that we use. Again, they all work slightly differently, but the end result is that they affect appetite and hunger. Orlistat's a little bit different because it actually affects the way that we absorb fatty foods. But those are several of the oral medications that we use. The alternative option would be the injectable medications. These are newer class of drugs, initially intended for diabetes management, blood glucose control. And what we found actually is that the side effect of them was weight loss. Again, it has to do with different signals to the brain regarding appetite suppression, also has to do with slowing digestion down. And essentially what they do is they mimic insulin. That's how they work for diabetes. And then again, the side effect would be weight loss. So these are the GLP-1 medications, glucagon-like peptide medications, liraglutide, which is also known as Saxenda, daily injectable that we use for weight loss, and then the semaglutide, which is Ozempic and Wegovy. These are weekly injections. Ozempic is used typically for diabetes management, and actually getting it approved through insurance would need a diabetes diagnosis, versus Wegovy, which is the ones that we prescribe in our office. These are being used for obesity management. So that criteria of BMI is what we use for approval of Wegovy. The kind of newest of these medications is going to be the tirzepatide, another injectable, which is a weekly injection. And this has GLP-1 activity, but it also has GIP activity, or gastric inhibitory peptide activity. So it's kind of like a dual insulin effect. These says Mounjaro, which is usually used for diabetes management, and then Zepbound is the equivalent medication that we use for weight loss. And this has now two different actions that cause kind of the same effects of slowing digestion and decreasing appetite. So what are the results that we're seeing on, I'm sorry, can you next slide? Thanks. The results we're seeing as far as the medications go. In general, oral options, we're seeing about a 5 to 7% weight loss. Some work better for different people than others do. And again, these are going to work best in combination with healthy eating and with exercise. Saxenda numbers are about 8%, maybe 10% weight loss. Daily injection, which is kind of fallen out of favor over the past year or so as the Wegovy and the Zepbound have become more popular and more common. So soon we probably won't be using that at all. Wegovy, we're seeing about a 15% weight loss. And this is after studies showing after about a year of use. And then Zepbound, which is the newest one and it has the dual action, we're seeing even up to a 21% weight loss, again, over about a year or so. Next slide. So I would say the medications have really impacted our ability to manage obesity and overweight in our patients. Patients who use the medications, and we prescribe a lot of them, either in conjunction with surgery prior to surgery, after surgery, in place of surgery. And we're finding overall really good success with the medications. I'd say definitely more so with the injections, but also with some of the oral medications. So what limitations do we have with the medications? First is going to be cost, which can limit access to the medications. And this is, again, specifically for the injectable medications. Out-of-pocket costs for these medications are over $1,000 a month, and we're using weight loss medications chronically. We're not using them for 3 months and stopping them. We're recommending that they be used potentially lifelong for treatment of obesity and then maintenance of weight loss. Oftentimes the medications are covered by insurance, but not for everybody. So it really, is a limiting factor for a large population of patients. Side effects. So the oral side effects, we're seeing things like high blood pressure. Sometimes we're seeing mood changes, constipation, fatigue, things like that. As far as the injections go, the side effects are more so on the GI tract. So we're seeing things like nausea, sometimes reflux, constipation, diarrhea, abdominal pain. Once in a while, we see gallstone disease becoming active, pancreatitis, things like that. Overall, again, I'd say in general, most of them are well tolerated. And if we can't find one that works, we might try something else to see, for that individual, what would work best. So there are those that are responders and those that are non-responders. So not everybody is going to lose 15 or 20% of their weight if they take one of the GLP-1 medications. We're not exactly sure why that's the case, but we do find that some studies have shown that they may be less effective in those that are type 2 diabetic or have more visceral fat. So again, they unfortunately don't help everybody. Availability was a big problem for some of the injectable medications over the past couple of years when there was a surge in prescribing them. Seems to have gotten a little bit better now, but the pharmacies don't always carry the medications. They're very popular. They can't keep up with the supply, and this is causing interruption in a patient's therapy. So they're on it for a few months and then they can't find the medication anywhere, have to stop it. And then what they're finding is that they're gaining their weight back without it. Long-term use, which kind of goes along with that. Like I said, we're recommending long-term use of the medication. There are not a lot of studies on this yet, but there is one study that showed if you stop the medication within a year or so, about 2/3 of the weight that you lost initially is regained. And we're seeing this again anecdotally in our office with availability issues or patients wanting to try coming off the medications. The appetite suppression disappears and then the weight kind of comes back to follow that. So again, I think that the medications are a great tool that we have to kind of supplement the other treatment options that we're offering, but they are limited as well for some patients. Next slide. So next up is going to be surgery. So bariatric surgery is currently a proven weight loss method. In the past, though, it wasn't. It was not always accepted as a safe option or as a go-to option for patients that were struggling with obesity. It was considered dangerous or an extreme way to lose weight. When we fast forward to the present now, our technique for weight loss surgery has changed, and with that, our opinion on surgery has changed as well. Surgery is now considered to be an accepted treatment for weight loss, and not only that, but it's actually still the best treatment for weight loss. So that is in the amount of weight that we can expect to lose with surgery, and also the long-term maintenance of that weight. We have also now, compared to initially when surgery started for weight loss, now we do all of our surgery laparoscopically or robotically, minimally invasive, so small incision surgery. And that has really changed the way surgical outcomes have been over the past several decades, which has made surgery not only effective, it's always been effective, but now it's making it effective, but also safe and low risk. Next slide. So as our opinions have changed, what we're also finding is that the trend in weight loss surgery has changed. So this is a look at the last decade of bariatric surgery volume in our country. And what we're finding is that since 2012 to now 2021, I think is the last time, we're having a gradual increase in the number of weight loss surgery that's being performed in our country. And this is probably due to a number of reasons. One is people's understanding that surgery is safe and effective, and also it's become more accessible. So now we're actually seeing insurances more widely covering the surgery compared to previously. Next slide. So what are the qualifications for weight loss surgery? So the BMI number is still what we use. It is just a little bit different now than it used to be. It is a little bit different, sorry, not what it used to be, but what the medication qualifications are. So we're using a BMI that's equal to or above 40, or a BMI equal to or above 35 with at least one obesity-related medical condition. You know, age is up here as a question mark because we really don't have a strict age cutoff, either young or old, for surgery. And I'll go into this a little bit more later on. We do want to document that there have been unsuccessful attempts at weight loss strategies previously, which most patients have been. Most people are not coming to us saying, I want surgery and I've never done anything else, right? That's usually kind of a last resort option. We do look for psychiatric stability, and everyone does have to undergo psychiatric evaluation prior to surgery. And the reason for that is because this is really a change. It's a lifestyle change. It's not a quick fix. And we want to make sure that patients are able to make those changes to really have the best success. Next slide. So those who don't qualify for surgery, one is any kind of active substance abuse problem, eating disorder, or psychiatric illness. Ultimately, surgery is elective. We do it planned, and we want to do it planned in the right way. So if any of these things are problems, we want to treat those problems first. Active smokers, we do not operate on. We know that smoking will increase risk of complications related to any type of surgery by 10-fold. And we want to make sure we're doing the surgery as safe as possible. And then finally, anyone who's just too high risk or too sick for anesthesia, their heart's unhealthy, their lungs are unhealthy, because again, the goal is to improve their health and their lifespan, not to endanger them. Inflammatory bowel disease, autoimmune diseases, those are things that we kind of look into a little bit more in detail, and we kind of go case by case in those patients. Next slide. So as I mentioned, surgery can be done laparoscopic or robotic. We call that minimally invasive, versus being done open with a big incision, which is how it used to be done 3-4 decades ago. And the great majority we do minimally invasive right now, which has really made surgery safer. It's made the recovery from surgery faster, less post-operative complications like wound infections and pain, and quick and hernia occurrences, quicker return to work, quicker return to normal function. As far as how the surgeries work for weight loss, we have those that are malabsorptive versus those that are restrictive. There is also a hormonal component to the surgery, which I'll explain in a little bit as well. So malabsorptive surgeries are the ones that kind of change the anatomy on the inside so that the way our bodies digest and absorb our nutrients is altered, and that results in weight loss. Restrictive operations are the ones that really just kind of make mostly the stomach smaller so that when we eat, we're restricted in volume as far as how much food can actually fit in the stomach. And we know that ghrelin is important in appetite, and that will change with certain operations as well, and that it contributes to some of the weight loss we see with surgery as well. The 3 main operations I'll talk about tonight are going to be the Roux-en-Y gastric bypass, the adjustable gastric banding, and the sleeve gastrectomy, though there are others, we can answer questions about any of the other ones as well. Next slide. So this is a little summary of the types of bariatric surgeries and how common they have been over the past decade or so as well. And what we're finding is that, so I don't know if you can see the colors here, but the purple, the orange, and the light blue on the bottom are going to be the duodenal switch surgery, SADI surgery, revisional surgery. So these are kind of similar to gastric bypass. These are very malabsorptive operations, and you can kind of see that their popularity, their prevalence really hasn't changed much over the past decade. The one in red is going to be the gastric bypass. And what we're seeing is that the gastric bypass kind of has these ebbs and flows up and down a little bit. The surgery that has really kind of taken off and really taken over for most weight loss surgical options is going to be the sleeve gastrectomy. This is true across the world. The reason for that, which I'll go into again a little bit later, is that it's very safe, it's very effective, and patients usually opt for the sleeve as their primary weight loss option because of those things. Next slide. So this is a look at all three of the operations kind of side by side, so you can get a sense of how different they are. So for the gastric banding, what we do is we put a foreign material, which is the band around the upper part of the stomach. You can kind of think of it as like a belt around the stomach, and that belt or band is attached to tubing. The tubing is attached to a port which sits under the skin. And what we're able to do is we're able to adjust the band. That means we can inflate the band. We can also deflate the band. And by doing that, we give more or less restriction on the stomach. The gastric bypass, which is the one in the middle, is a mouth. So the banding is a fully restrictive operation. The bypass, which is the one in the middle, is our kind of gold standard operation for weight loss, has been around forever. And what we do here is we do a little bit of restriction and mostly malabsorption. So we make the stomach into a small pouch, and then we reroute the intestines. So we're making two separate anastomoses or connections, one between the stomach and the small intestine, and one between the small intestine and the small intestine. And what we do is essentially we kind of change the way our body digests and absorbs food. So one limb carries the food, one limb carries the digestive enzymes, and they meet at a later point in our intestinal tract, and that leads to malabsorption. So our body is kind of absorbing and using less of the calories we're actually eating. Finally is the sleeve gastrectomy. That involves cutting and stapling the stomach, or removing about 70 or 80% of the stomach from the body. We're causing significant restriction with eating, but the sleeve also has that hormonal component, because that part of the stomach that's removed is responsible for ghrelin production. And what we find is after surgery, the hormone is reduced. So there's also less of that appetite feeling after surgery, that hunger. Next slide. So I'll go into each just in a little bit more detail. So the gastric bypass, like I said, is kind of our gold standard operation for weight loss. It's been around for a long time. It works really well. We're seeing 30 to 35% weight loss with this operation. The weight loss happens very quickly. It's significant, and it does show long-term maintenance of that weight for the majority of patients and the majority of the weight. Along with the weight loss, what we're seeing is significant improvements in medical comorbidities. It works potentially better for those patients that have higher BMIs, or that those that have a history of type 2 diabetes. There's no implant, so it's not like the banding where we're putting something foreign inside the abdomen. And it's also, like I said, been around for so long that we have lots and lots of information about outcomes related to this type of surgery. Next slide. Some of the disadvantages or negatives of this surgery. Of the three that I'm going to talk about, it is the most invasive of the three, because we are changing the anatomy on the inside, and that comes with risks, unfortunately. Some of those risks include leakage at any of the connections that we make of the stomach and the small intestine. That's essentially a bad bacterial infection. If intestinal fluid leaks in the belly, can make a patient very sick. Other infections or abscesses can occur kind of along that same thought. Also, because we're rerouting the intestines, there is a higher chance of intestinal blockages. We call those internal hernias, where the intestines can kind of twist on themselves on the inside. That typically would require surgery to fix, and sometimes emergent surgery that can, again, make you really sick if it does happen. Long term, there's always a concern for malnutrition, vitamin deficiencies, anemia. Since we are altering the way our body digests and absorbs certain nutrients, we have very close eye on follow-up, making sure that certain vitamins, minerals are at appropriate levels, and this should be done for the lifetime of the patient. They should be on nutritional supplementation to ensure that their numbers are where they're supposed to be. Dumping syndrome is sometimes something that we see, which can result in symptoms of diarrhea, nausea, vomiting, bloating, and that usually is managed with changes in the diet. Sometimes high carbohydrate foods can cause the symptoms to occur. As I said, this is overall the riskiest or most invasive of the operations. Overall death rates are about 1 in 200. And as with all the operations, there's always a potential for weight regain if those healthy habits of eating right and exercising are kind of lost over time. And we see that happen in probably about 25% of patients. Next slide. So the gastric banding came about in the early 2000s as an alternative to the gastric bypass that was thought to be safer because it didn't involve any cutting, stapling, changing of our anatomy. And it also lacked some of those long-term complications that the bypass had potential for. So those are things like dumping syndrome and intestinal blockages and things like that. So it was the other thought behind this procedure is that it's completely adjustable. So everyone needs a different amount of fluid and restriction. And it's also reversible. If it's not working or if it's causing any problems, the band would come out and you still have your normal anatomy there. It is the safest of the operations, about 1 in 2,000 mortality. And the operation was often done as an outpatient, again, laparoscopic. And it was very popular for about a decade or so. Next slide. The problem with the band, though, is that we didn't really find the same weight loss benefits. The weight loss was definitely slower, and it required regular follow-up to really achieve the adequate restriction on the stomach. Like I said, everyone's different. And if patients disappear, don't follow up with their doctor, then they could have complications related to the band or just not enough weight loss because their restriction isn't right. We were seeing about a 15 to 20% weight loss with this type of surgery, as opposed to that 30% that I mentioned with the bypass. So again, safer operation, but overall results just weren't as good. Some potential complications or side effects are infection. So again, it's foreign material inside your body. It's not supposed to be there. So that poses risk of infection. We also, most commonly, we're seeing things like reflux, heartburn, dysphagia symptoms if the band was too tight or if it moved a little bit where people are having trouble with eating. Band slippage is when the band orientation moves to such a degree that no food can get down into the stomach. That typically requires emergency surgery to fix, or erosion of the band into the stomach. If the band over time is too tight, then it can actually kind of slowly erode into the stomach. And we have taken bands out that were supposed to be on the outside of the stomach that were on the inside of the stomach. So again, it's not without complication, despite it being overall a safer operation. An older study showed that after 10 years follow-up, we were removing over 40% of bands. At this point, I'd say that number is probably closer to 60 or 70%. Next slide. So the sleeve gastrectomy is kind of the newest of the operations that we're doing for weight loss. It involves cutting and stapling the stomach, as I mentioned earlier. And what we're finding with this operation is also kind of rapid weight loss that is maintained over time. When we compare the weight loss of a sleeve to a bypass, they're almost equivalent, not quite, but almost equivalent. And with that weight loss, we're seeing significant improvements in those medical comorbidities. And part of that has to do with not it just being a restrictive operation, but also that hunger hormone aspect, which we see with the sleeve that we don't necessarily see with the banding. The sleeve gastrectomy, because it's safe, because it's a fairly quick procedure, is really safe for a wide variety of patients, those that have higher BMIs, those that are a little bit older, and we're finding that it kind of works for everybody. There's no implant. There's very rare do we see any long-term nutritional deficiencies because you're still absorbing everything the same way, and we pretty much never see dumping syndrome. Mortality rates are about 1 in 500. So we think of it kind of like in the middle as far as safety goes between the banding and the bypass, but it is almost as effective as the bypass. Next slide. So some potential risks or complications, leakage along that staple line. So again, if the stomach staple line doesn't heal properly, then stomach fluid leaks in the belly. Those are treatable, but they can take time to treat. We do see that there is some stretching of the stomach over time. So a nice skinny stomach initially probably will be a little bit bigger years later, and that can lead to some regain of weight, especially if those habits aren't there. We can see some ulcers of the stomach. We can see narrowing or twisting of the stomach. I'd say overall that's pretty infrequent, but not impossible by any means. And it is a non-reversible operation. We're taking part of the stomach out. We can't give that back to the patients. It's permanent. Of the procedures, it is the newest of the procedures, but it's been around now over a decade as an FDA approved operation for weight loss. So we do have a lot of studies and data on it at this point. Next slide. So when we look at weight loss outcomes of the 3 operations side by side, and I kind of hinted to this earlier, most studies, what we look at is the percent of excess weight loss. So how much, if someone's 100 pounds overweight, how much of that excess weight are we losing? And what we find is that the lap band, we're seeing about a 50% excess weight loss. I mentioned that's about a 20% total weight loss. And then and this is kind of maintained over 4 to 5 years. With the gastric bypass and the gastric sleeve, we're seeing not quite the same, but kind of mirroring each other, where the weight loss is more rapid in the beginning compared to a banding. It kind of peaks around that 70 or 80% excess weight loss, which again translates to somewhere between 25 to 35% total weight loss. And then over time, a little bit of weight regain, but those two lines there are fairly similar to each other as far as weight loss results go, which is why the sleeve has kind of taken over as the most common operation. We're seeing very similar results for weight loss and therefore an improvement in medical comorbidities without the risks that go along with the bypass. Next slide. So as far as outcomes go, we define successful surgery in one of a number of ways. One is greater than 50% excess weight loss. So if someone's again 100 pounds overweight, and we use their ideal weight and their true weight to kind of calculate that, we consider that successful. We're looking for about over 20% total weight loss, or we're looking for achievement of a BMI under 35, so they no longer qualify for weight loss surgery. We see peak weight loss happening between 2 to 3 years after surgery, and on average, we're seeing about a 70% success rate 5 and even up to 10 years after surgery. And this is specific for the gastric bypass and the sleeve, not necessarily for the banding. Next slide. So again, as far as outcomes go, what we see is improvements in multiple comorbidities. I think this slide is a great one that just kind of summarizes it for us. We know that overweight and obesity can affect every organ function, every system in our body. And this kind of summarizes how we're seeing improvements in those things as well. So improvements in depression and anxiety, sleep apnea, high cholesterol, asthma, cardiac disease, high blood pressure, type 2 diabetes, PCOS, and the infertility that comes with that, joint disease, arthritis, and overall what that translates to is improved quality of life for patients and also reduction in mortality in patients who are now healthier weights and therefore healthier overall. Next slide. So just to summarize, why is bariatric surgery kind of still the best answer for patients who qualify for bariatric surgery? One, it's the most effective strategy for weight loss, and we're seeing a 30 to 35% total weight loss in comparison to anywhere from 5 to 20% weight loss with diet, exercise, and medications. Not only that, but the weight loss is sustained for the majority of people 5 and 10 years and even longer down the road. Along with that weight loss, we're seeing improvement in multiple medical conditions. So this is considered a metabolic surgery. We're actually changing comorbidities. And what that leads to is an improvement in survival. So obesity is the second leading cause of preventable death in the United States. And we're seeing shortened lifespans for those that are obese compared to those that are non-obese, that are the same age otherwise. And that mortality increase is happening at early ages, even in the 20s. So our goal is to improve weight, thereby improving medical conditions, thereby improving survival. Next slide. So I talked a little bit about age. So we do have our adolescent bariatric surgery program here at Jersey Shore. The adolescent population weight loss surgery essentially is approved for anyone 14 years old and above. And same with the senior population, which we consider 65 and above. There's really no age cutoff as far as I'm too old to operate, and we kind of use our judgment for that. So, we've operated on patients who are in their early 70s who are otherwise healthy, active people, but who really struggle with joint disease, or just being active and things like that because of their weight. And what studies have shown is that in both of these populations, surgery is effective and it's safe. Really no change in the adolescent population, the senior population compared to the ages in between. We're seeing equivalent weight loss results when we compare them to adults, and we're really seeing no difference in complication rates when we compare them to adults. So again, for everybody, yes, we try other options first, medications, diet, exercise, these programs. But if surgery ends up being the final option, it's actually a great option. And in fact, in adolescence, it may actually be a better option to do it when they're younger, before they start experiencing some of those medical comorbidities, to help prevent them from developing as well. As far as revisional surgery goes, we do a lot of revisional surgery, and what multiple studies have shown is that the weight loss results are not quite as good after revisional surgery as they are after the primary surgery. So for example, if patients were going to have gastric bypass surgery, their results, if they had went straight to gastric bypass, are actually going to be better than if they have had a sleeve and then a gastric bypass. So that probably has something to do with having had surgery, but it also probably has something to do just with the patient. They might just not be someone who's going to do as well as the next person with their results. Next slide. So in conclusion, obesity is a major epidemic in our country. We do offer multimodal treatment, which includes diet, exercise, behavioral programs, medications, and surgery. It is a lifelong disease and it requires lifelong treatment. So, and that includes all those things that I just mentioned. Diet and exercise is crucial for everybody who's doing it, and that is part of why lifelong treatment, it's part of the lifelong treatment plan. There's a big potential for medications, I think, in this field, which is why we found it to be an important thing to include in our practice, because it only adds to the effectiveness of surgery, and we're able to now offer things to our patients if they don't qualify for surgery too. Ultimately, we feel that for those that qualify for surgery, the morbidly obese patients with BMIs over 40, the best option is still probably surgery, because of the amount of weight we're hoping to help those patients lose, to get them down to a healthier BMI category. And that was it. I think we have some time for questions. Thank you.
Thanks, Dr. Arumugam. So we have our Q&A function. It's enabled. So if you have any questions, I know there's one question in here, but please feel free to enter them in and we will do our best to get to all questions.
I'll jump in at the first question that was in there. It was about a medication that I believe is an herbal medication. We are only really prescribing FDA-approved medications through our practice because those are what's controlled, regulated. There are lots of different interventions for weight loss that are not FDA approved, and those will always be around. So really what we're focusing on at Jersey Shore is what is fully FDA approved, research studied. We stay within the rules that the FDA has laid down for each of these medications, and that's what we're prescribing. If you're not eligible and you don't meet the rules that the FDA has set up, then we're not prescribing them. So we're really just following those strict rules for all of that. The only other comment I'll make is we've loved being at Jersey Shore Medical Center because it's one of the best hospitals in the state over the last 15 years. It has steadily improved. So those are certainly things that have helped us because there's every other type of doctor we ever need. All right, I'm now seeing a boatload of questions. I don't know if Dr. Arumugam wants to take some of these. They are flowing.
You know what? I can't see them because I'm logged in on my phone.
Perfect. So I'll start with phentermine is not supposed to be continued forever. You're supposed to start phentermine and continue it for several months. We sometimes give people breaks over the summer. It's one of the oldest weight loss medications that's out there. So that is something that is unique about phentermine as a medication. We do often use lower doses of phentermine as well as in a combo pill with Qsymia as phentermine with a different medication, and that often is very helpful. They are bouncing all over the screen. There are many different apps. When you meet with our registered dietitian, I'm sure she could go over different apps that may be useful to help you track your diet and weight over time. We have all of our patients see a registered dietitian when they meet with us. They don't need it on their first visit, but at some point they do need to go over food and what they're eating. What else? The sleeve is ridiculously safe as an operation, but weight loss medications like Ozempic or Wegovy are not an operation. So often we start medications on lots of patients and see how they do. If you're doing well with Ozempic or Wegovy, that's great. If you're one of the non-responders, we start talking about surgery. The big issue with all weight loss interventions, the risk of being overweight is far scarier than the risk of surgery or the medication. So we absolutely want to do anything we can to get people out of those high BMIs and morbidly obese categories, because you're far more risky and have a shorter life expectancy from just having that obesity. So I know there's fear of weight loss surgery, but there should be a bigger fear of obesity. All right, so that's done. So we do see people regaining weight, and one of the reasons we got into weight loss medications is because we were seeing people that had weight loss surgery years ago and were regaining weight. Those people are doing excellent with the weight loss medications. We really are able to drop weight quite nicely. The sleeve does allow people to accommodate more food over time. And if you're not following routinely up with the proper diet and exercise, you can regain weight no matter what we do.
Yeah, and I'll just
the supply, go ahead.
I was just going to add that what we're seeing actually, and this is kind of anecdotal, we're looking into it as a research project, is that patients who've had prior weight loss surgery and then gain weight and start the medications actually have really, really good success on the medication. So again, we're using it really in adjunct with those who've had surgery already. And, you know, my feeling is that because they already have that anatomical restriction, adding the medications gives them even more weight loss benefit.
Another question. If someone wants to call our office and just make an appointment with a nutritionist, they're welcome to do that. Lindsay Benton is on the same floor with all of us. And if you just want to see a registered dietitian who to help you lose weight, you absolutely can call our main office number to do that. We do take Medicaid and most insurances, and most insurances are beginning to improve weight loss surgery coverage over time. It is expensive to take Wegovy if you're not going through insurance. So we really do our best to see if we can get it covered. And our office does a great job at doing that. With weight loss medications, it's hard to pay out of pocket. And we do recommend using the medications that come from the pharmaceutical company and not the compounded forms of these medications that are not regulated by the FDA. Supply issues have resolved, so it's much better. Our office maintains a list of pharmacies in Monmouth and Ocean County to help direct you. If your particular pharmacy doesn't have the drug, our office can help you find that drug. There are many different autoimmune diseases and other diseases that when you meet with us in the office, we will go over what you have, what your risks of surgery. We sometimes will do x-rays and other workups to see what type of medical disease you have and address those things over time. Appetite is real, and we are looking to suppress your appetite. We are wired to store calories and to hibernate and to not have food all winter long and not to have food every day. So we are working against our evolution, and that's partly how a sleeve gastrectomy works, because the top part of the stomach supplies your appetite, and these medications suppress your appetite. So as Dr. Arumugam said, combining those two, we're really seeing people lose a lot of weight. I don't know what the short-term drug, what that question's about. Mobility is tough. If you're not able to walk and move, and we can get you to lose weight and improve your mobility, you'll do well. If your mobility is permanent, it is very difficult to chronically lose weight. So that's something we will address in your office. But if you're trying to get a hip or a knee replacement because you're immobile, we want to get the weight off of you, then get you through a hip or knee replacement and improve your mobility. Wegovy and Ozempic are the exact same drug. They are FDA approved for different indications, and Wegovy has higher doses. So we are able to get you a more potent effect if we're using Wegovy than Ozempic. But Ozempic did come out first, and then they rebranded it to have a primary indication for weight loss. I think someone cleaned up all the questions.
Yes, thank you so much for getting through those questions. Last call for questions. If you don't have any questions, then please keep an eye out for our feedback survey. We'll be sending that out with the recording of this presentation later today. Feel free to share it with your friends and your family, and we hope to hear from you soon. So that concludes our program today. Thank you so much to everyone for joining. Thanks to our doctors for presenting. Our contact information is here on the screen. And again, that feedback survey, you can request an appointment through there and we'll connect you to our team. So have a great day and thank you again for joining.
Thank you.
All right.
Thank you, Kelly, for taking care of all that.
You're welcome.
Goodbye.
Thanks, everyone. Bye.